ABG interpretation case study Aglan protocol. How to study ABG? 4 items. Number 1, listen carefully to the clinical history. Number 2, study the lab investigations including the ABG chart. Number 3, look at this Aglan ABG table to fill in the spaces measured and calculated. Number 4, back to this Aglan ABG table to study pH, chloride items, bicarbonate items, oxygenation state of the lung, and ventilation state of the lung. Clinical history. Study of the clinical history will be important for 2 things. Number 1, to anticipate the pathophysiology. Number 2, to anticipate the sequelae of events. Anticipation of the pathophysiology, like what? If the patient is vomiting, he's going to lose chloride, gain bicarbonate, to develop hypochloremic metabolic alkalosis. If the patient develops diarrhea, he will lose bicarbonate, gain chloride, to develop hyperchloremic metabolic acidosis. If the patient develops diabetic ketoacidosis, bicarbonate will be consumed, so he will develop high anion gap metabolic acidosis. In a renal failure patient, bicarbonate will be consumed by the fixed acids to develop also high anion gap metabolic acidosis. Methyl intoxication will be associated with the formation of formic acid to consume bicarbonate to develop high anion gap metabolic acidosis. Stable congestive heart failure, the patient will have hyponatremia, maybe on diuretics like furosemide to develop hypokalemic metabolic alkalosis. Liver cirrhosis patient will have hyponatremia, hypoalbuminemia, hypokalemia, and develop metabolic alkalosis. Anticipation of the sequelae of events, like what? If the patient develops vomiting, then became shocked, vomiting will develop hypochloremic metabolic alkalosis, then shock will develop high anion gap metabolic acidosis. Lab investigations you should study sodium, chloride, potassium, BUN, serum creatinine, random blood sugar, ketone bodies, and serum lactate. Then come to the ABG chart to study it, to see the values. For the calculations of the calculated items, don't forget these formulas, these equations. I collected it in the form of golden rule in these 4 slides. You should know it by heart. Number 3, look at the Aglan table and fill the spaces. These spaces are 2. Number 1, the measured items will be taken from the lab investigation and the ABG chart. Then the calculated items with these red arrows, you have to calculate it before starting the Aglan ABG table. Number 4, study Aglan table. This Aglan table, as I have mentioned before, is formed of measured values and calculated values. To start with, number 1, by the pH. Number 2, the chloride items. Chloride items, serum chloride, chloride sodium ratio, corrected bicarbonate, and strong ion difference. Number 3, bicarbonate items, serum bicarbonate, anion gap, buffer base, strong ion gap, base excess. Number 4, oxygenation state of the lung, FiO2, BO2, arterial oxygen, partial of oxygen of arterial oxygen, and alveolar arterial gradient. Number 5, ventilation state, the partial of carbon dioxide and its relation to the pH and bicarbonate. To study the pH, for sure, see whether is it normal, the acidemia, or alkalemia. Start studying the chloride atoms. Number 2, as I've mentioned before, serum chloride, chloride sodium ratio, anion gap, strong ion differences, and corrected bicarbonate. From these items and from these data, you will come to the diagnosis of the start pathology, the first pathology. Number 3, studying bicarbonate items, serum bicarbonate, buffer base, base excess, strong ion gap, and anion gap. This will give you the last or the second pathology and the second diagnosis. Number 4, the oxygenation state of the lung will be studied through studying FiO2 and BaO2, and you will come to the formula alveolar arterial gradient to diagnose the oxygenation state. Is it normal or hypoxic? Number 5, studying the ventilation state through studying the partial of carbon dioxide correlated with bicarbonate and pH. See whether the patient is hypoventilated, hyperventilated, normoventilated, compensated, or not. Case number 1. 45 years old alcoholic man has been vomiting for 3 days. This is number 1 pathology. Vital signs: blood pressure 170, hyperperfused, pulse rate 110, was given in the ER Valium high dose 30 mg. So consider here 3 important pathology: vomiting, hyperperfusion, and Valium. pH thermal 3, partial pressure of carbon dioxide 40, bicarbonate 19, partial pressure of oxygen 78, sodium 145, potassium 3, chloride 96, serum ketone positive, FiO2 21. Let's come and study Aglan ABG table. The first thing to study is the pH. pH here is 7.3. This is acidemia, most probably metabolic, low bicarbonate, and we'll see that there is other pathology which is respiratory acidosis, high bicarbonate. Then come to the second item, which is chloride. Here the chloride items: sodium chloride, serum chloride is 96, it's low. The ratio between chloride and sodium is 66, normal is 74, so this is not a dilution, this is hypochloremia. When we come to the strong ion differences, it is more than 40, so this hypochloremic metabolic alkalosis. Come to the corrected bicarbonate, 737. So this patient developed vomiting to have hypochloremic metabolic alkalosis. Then what happened? This patient developed some sort of hyperperfusion. Bicarbonate dropped from 37 to 19. So there is some sort of metabolic acidosis. Come to the buffer base, less than 40, metabolic acidosis. Base excess or base deficit, there is base deficit, this is metabolic acidosis. This metabolic acidosis due to the presence of fixed acid. What is it? This is strong ion gap is 14, more than 0. So this patient developed a high anion gap, yes, 30. This patient developed high anion gap metabolic acidosis after the first pathology, which is hypochloremic metabolic alkalosis. The third part to study is the oxygenation state. Oxygenation state, this patient was on room air, 50221. The calculated alveolar partial pressure of oxygen was 90. The measured arterial oxygen 78, and the alveolar arterial gradient was 12. This is normal, so there is no problem for the lung oxygenations. When it comes to the carbon dioxide, it's 40. The expected carbon dioxide from this 19 as 34, but it's 40 due to the effect of barium. So this patient developed a respiratory hypoventilation with respiratory acidosis. So the final diagnosis is hypokalemic metabolic alkalosis, followed by high anion metabolic acidosis and hypoventilatory respiratory acidosis. Thank you.